Hello everyone, Dr. Padmanabhan here. Um, uh, this video is about a movement disorder in the old people. It's called Parkinson's disease. Parkinson is just a name, as I know, a Britisher probably. Parkinson's disease, but in our language it is called Kambavadam, because Kamba means shaking. So shaking of the limbs is supposed to be the, but as we go into it, we see that shaking is not the main thing. Shaking is otherwise called tremor. Tremor. Medical term for shaking is tremor, like this, But the better terminology is probably a variant of kinesia or chalanam. Kinesia comes from the Sanskrit word chalanam. Cha becomes ka. That's how kinetic, kinesia, all those things. So it's called dyskinesia. Dyskinesia means abnormal. So dyskinesia. Or sometimes if it is excessive, it's called hyperkinesia. Hyper. So actually tremor is a hyperkinetic disorder, hyperkinesia. So the reverse of that is hyper becomes hypokinesia. It's a real movement disorder, not able to move much. Hypokinesia. So it's basically it's defined as a hypokinetic or Parkinsonism itself is called idiopathic. Idiopathic means idiom actually comes from the Sanskrit word swayam, idio. So it's supposed to be, we don't know why it happens. That's why it's called idiopathic. It's supposed to come on its own. But we know the etiology, the reason is, but we are not sure why it happens. Why it happens in old people, we are not sure. All we can say is that it's a neurodegenerative disorder. Degeneration, no. When you become old, all kinds of degeneration come to your body. It happens to your brain. It happens to your joints. It happens everywhere, eyes, everything. So it's a neurodegenerative disease of old age, which one? Parkinsonism. It's also idiopathic because we are not definite of the etiologies, although we have some clues about it. It could be because of the environmental factors, the poisons, neurotoxic poisons, or it could be genetic. There is some genetic studies, there's chromosomes involved, especially in Parkinsonism is mainly two types. One is the young onset and the old age onset, the late onset. So especially in the young onset means before 50 years. Old means after 60 years. 60, 65 years, that's called late onset Parkinsonism. But generally, Parkinsonism is an old age disease. The older you become, the more chance of you getting Parkinsonism. But all that shakes is not Parkinsonism. The shaking is just part of it. Parkinsonism is a akinetic disorder. The movement is difficult. Muscles can become stiff. It's called hypertonicity. Muscles, especially, that is tested by testing your wrist joint. Muscles attached to wrist joint is tense. It is this one hypertonic. Tonicity, the tone of the muscle. It's how the muscle is like in a chanda. Chanda means the drum. You have got all this, the lines, the ropes around it, which keeps it taut. like that the muscle has got a tone. It can become hypotonic. Actually, it is under your volition. You can control your tone to some extent, but involuntarily involuntary means without your knowledge there is a tone in the muscle. So that tone is high in Parkinsonism. Why does it happen? Because the tone is the tone of the muscle, and the movement itself got some it has got a some algorithm. In the movement algorithm is present in the part of brain called midbrain region. Midbrain is, it's called a kind of ganglia, means a collection of neurons, So there are some ganglia called the basal ganglia. There are related structures. Related to the thalamus, that's called substantia nigra. Substantia nigra means black substance. It's all called pigmented cells. So Parkinsonism affects these pigmented cells. So the definition can be that a hypokinetic, the chalanam is less, hypokinetic movement disorder with changes in the pigmented cells of the midbrain and the other areas. And also one proviso is that there is a kind of protein called Levy body. It's a kind of protein called synuclein. I don't know why, maybe some connection to nucleus is there. Synuclein, this Levy body has to be found in this basal ganglia. That is on biopsy. Then you can say that that is postmortem biopsy. If the person was suffering from Parkinsonism disease, he should have Levy bodies in the substantia nigra or whatever, that area, basal ganglia area. By the way, see, my geriatric talks are not directed to the super specialist or the real people who treat all these things. This is directed to the general practitioner and the general population. So, see, I don't want or I don't intend to take away any of your prerogatives as a specialist in this. This is not directed to, for example, this talk is not directed to a movement specialist. It's not a director's movement. This is directed to a general practitioner, and general practitioner also includes this one, what you call physician, general medicine. It is to them because I am dealing with an aspect of general medicine called geriatry. I'm not a specialist in that. I'm a vascular surgeon. But why I do it is because geriatry is a neglected specialty in our country, and especially in Kerala. That's why I'm doing it. And also I'm interested because primarily I'm doing it for myself and to a few of my friends. For example, this video I am doing for a friend in Bombay, Karnagaran, because he asked me, he has some friends with Parkinsonism and all those things. So I thought I will do something. I do it in English because they can also understand. People in Bombay can understand. That's why I'm doing these things. Anyway, so this is a definition of Parkinsonism. It's called idiopathic Parkinsonism. We don't know why it happens. And the Parkinsonism is a kinetic disorder. And please don't think that Parkinsonism affects only the movement. It affects all aspects of the human body, all aspects of our brain function. Finally, it will affect our cognition, our thinking ability also. It affects our social interaction, everything. So it's not just a movement disorder. It's an affection of the brain. It can affect various parts of the body. Although it starts in this thing, it's supposed to start at the belly. Actually, it affects it's supposed to affect first affect the nervous tissue in the abdomen, and then abdomen, and also the olfactory nerves, olfactory nerves, and also some areas of the lower part of the brain called the where the lower cranial nerves and all that come, that medulla, that area. They are supposed to be affected years before it affects the basal ganglia. That's why people having constipation about a decade ago, later on they can, I'm not scaring anybody. No, it may not be, regular constipation. And also somebody having this thing, anosmia. But anosmia, you have to be careful. Anosmia, careful in the sense that it can develop into anosmia, again idiopathic. We don't know what's the cause, because it affects the olfaction. Olfaction means smelling, the capacity, olfactory nerves. These are the first nervous tissue which is affected, but it affects all parts of the brain. So this is the neuropathology. It produces what's called gliosis, the connective tissue of the brain will be more in the brainstem nuclei. See, these Levy bodies, I said, the degenerative protein products may be seen in normal people also. Up to 10% of normal people will have Levy body in the brain on postmortem. So it's not a sine qua non for Parkinson's disease, but for diagnosis, it's a diagnostic, one of the diagnostic criteria. You should have a Levy body in basal ganglia. But we are not sure whether that is a cause of this one. Then this one, I said motor features. Motor feature means the features which determines your chalana. Motor means movement. The kinesia. So akinesia. There is a decrease in spontaneous voluntary movement. And the execution of movement will become smaller. Actually, neurologists will test this by, it becomes slow, your motor function will become slow. Test called the finger tap test. The thumb and for finger, I asked to tap as fast as possible, like this. And after some time, what happens in Parkinson patient is that this movement will become a little slow, because they won't be able to, like this, easily. It will become a little more difficult, it is slower. That is one way. Another thing is the toe tap test. The same thing can be done with the foot also. This is one diagnosis. Then they will check your this thing, the tone of the muscle, that there is hypertonicity or not. So that's called rigidity. If you are supposed to have rigid. Even truncal muscles, this is the neck and the central part of the body, that can also be affected. So they will check the movement of the neck. It may not be very spontaneous. It becomes rigid. All voluntary movements will have low amplitude. In fact, even your voice will become low, because voice is produced by muscles. So when you become in well-established Parkinson's disease, they will have low voice, even whispering. Then the movement, I said, is not the hallmark, but it is seen in about 70% of Parkinson's patients. Why is it not? Because movement is this tremor is seen in many neurologic conditions. Later on, they will go into difficulty swallowing, difficulty speaking, and all that, because it will affect the speech muscles, the swallowing muscles, and all those things. These are the motor symptoms. Motor means that is affects the movement of the hand, how we move about, all those things. There are non-motor symptoms also. See, it's not merely movement. Non-motor is also there. As I told you, they will have hyposmia. Hyposmia means a decreased sense of smell. Then sleep disorder. Then constipation, I told you already, this, because it begins in the belly. Then Parkinson's patients also unfortunately develop dementia. In fact, the incidence of dementia in old age Parkinsonism of long duration may be up to 80%. But dementia is not Parkinsonism. Parkinsonism is a movement disorder, but dementia will come on later. But if the dementia comes first, and even some people can have Parkinsonism features later on, then it's called Parkinsonism plus. Means Parkinsonism is not the primary thing. They have dementia, then they develop Parkinsonism. And there are main brain, a lot of brain conditions in the brain which will produce Parkinsonism, but they will have brain features, cortical features, what is called cortical features, dementia. They will have decrease in executive function, like that. They can have psychosis, madness. They can have even depression. Depression is quite common in. And also old age Parkinsonism people can have visual hallucinations. They can see things which are not there. Visual hallucinations. Another thing is, the drug treatment of Parkinsonism, there is mainly only one drug. I am coming to that later on. Can itself produce some amount of brain features. Especially, it can produce what's called delirium. Delirium means it's a cognitive disorder, but the person will be completely out of whack, in the sense that you won't have sense of where is the environment, You won't have any idea, or the people around you. You may not know, even as close relative. That's called delirium. It's not dementia. Dementia means a long-term process. Delirium means acute, coming acutely. So, anti-Parkinsonism drug can produce delirium. But delirium per se is also seen in this one, Parkinsonism patients. So, how do you diagnose, Diagnosis, I told you that all the movement will become decreased. Then the handwriting will become smaller, becomes a scroll. It's called micrographia. On an early sign of diagnosis, the difficulty in turning in bed. Then gradual decrease in walking speed. Then one important feature is salivation. The saliva is under control of the masticatory apparatus. So there is a defect there. The excess saliva could be, it's called drooling in common language, or it's called siloria in medical terminology. Siloria, drooling is good enough. Drooling. So a lot of drooling. Everybody drools, but they will drool a lot. And they will need a treatment for it. The treatment for drooling is injecting that toxin, injecting toxin into the salivary gland, submandibular parotid. It's called this one. What is that? Botulinum toxin. The other day we were talking about botulinum in some context. So botulinum toxin injection is good for siloria. If you are making a diagnosis for general practitioner, if you want to make a diagnosis of this one Parkinson's disease, there are some exclusion criteria. So the exclusion criteria, they should not have been exposed to antipsychotic drugs called neuroleptic drugs, antipsychotic drugs. They should not have taken drugs treating their mental disease before. Then if anybody has some clue to, if the patient has a cerebellum is part of the brain, cerebellar or corticospinal means it's a tract which comes from the cortex of the brain. These signs are there for a GP, then you should not make a diagnosis of. They may have shaking and even drooling also. But if you have got presence of corticospinal or cerebellar tract sign, don't ever make a diagnosis of Parkinson's disease. Or they had a history of multiple strokes. After strokes, the brain will become damaged. Everybody knows that. Then there are stepwise strokes are there. Then they can get all the Parkinson's features. Then later on they will become demented also. So don't make a diagnosis of Parkinson's disease in such cases. Then if somebody had early autonomic failure is usually, autonomic means the body has some automatic neural reserve. It's called the autonomic thing. The first thing is the keeping upright itself is an autonomic thing. So those who have autonomic failure will have sudden falls, because they can have sudden fall in BP, they will fall down. Even otherwise they will fall down because of muscle weakness. That's called autonomic failure. They have severe autonomic failure early. Late onset Parkinson's disease, fall is a feature. Parkinson plus fall is a feature. So they don't make a diagnosis of Parkinson's disease if they have early autonomic failure. So that means they have autonomic nervous system also produces this one or involved in things like sweating. They'll sweat a lot in some situations, or they don't become dry. Then that's early autonomic failure. Another thing is what's called supranuclear gaze palsy. The movement of the eye is it is controlled by two structures in the brain. One is the lower part of the brain, the basal part of the brain, or the medullary part of the brain controls the automatic eye movement. If you turn your eye to this side, the eye will go to that side. Both eyes. Turn your head. That's an automatic movement. So that will go off when you have a medullary problem. That is, somebody has a brain dead. You will not have automatic movement of the eye. But that's not the one eye. The supranuclear means the cortical, from the upper part of the brain. If you ask the patient to move his eyes voluntarily, like move leftward, rightward, like people in Kathakali do, they won't be able to do it. So it's called supranuclear gaze palsy. If somebody has supranuclear gaze palsy, again, don't ever make a diagnosis of Parkinson's disease. But in short, you can never make a confident diagnosis of Parkinson's disease in old age. Sometimes it's a trial and error with L-DOPA. That is the medicine for Parkinson's disease. This is not said to disparage anyone. I'm not disparaging a specialist. I'm just saying, hey, this is the truth from the book. But I also see old people. That's why I got interested in this. Vascular surgery. Vascular surgery is all old people medicine. But if you have, there are several this thing also, some imaging also there to help you in diagnosis. But I don't know if it's available in this part of the world. It's called a dopamine transport aspect. It should be available somewhere, at least in Calicut. The dopamine transporter SPECT. SPECT means single photon emission CT. That's a dopamine transporter. Dopamine is there on the substantia nigra and basal ganglia. Dopamine depletion is there, Means, the dopamine is producing cells are not producing dopamine. That's why the Parkinsonism comes. So that can be tested. That's supposed to have a good about 90% reliability. Then the subtypes of Parkinsonism is I told you early onset before 50, late onset after 60 years, and then some people will have tremor. 70% will have tremors. They can be without tremor. Then slow progression versus fast progression. Fast progressing Parkinson's disease is a late onset, after 60 years, late onset Parkinson's disease. They will have more of this one upper brain problems, falls. Then the early onset, more tremor, and supposed to be more benign. Then you can also say if somebody has Lewy body in the brainstem, Lewy body in the cortex. Lewy body in the cortex, Parkinson plus. Regarding epidemiology, worldwide epidemiology, I think uses statistics. It's around 100 per 1 lakh. That's 0.1%. So it's less than, of course, common schizophrenia and all those things. But it is strongly age associated. As you grow older, more Parkinson's disease. Then management is not drug treatment alone. Management is the whole management of the patient. How the caregiver gives care to the patient is management. But drug management is you have to increase the dopamine in the brain, in the basal ganglia. If you inject dopamine, it will not go into the brain because there is a blood-brain barrier. So the only way you can give it is giving it orally by a drug called L-DOPA. L-DOPA. The L-DOPA will get metabolized, not metabolized, it will get altered in the bowel. So you give by a decarboxylase enzyme in the bowel. So you give an anti-decarboxylase drug also along with that. So it gives absorbs to a large degree, fairly good absorption. But it should not be given with protein-containing food. Better to give it on empty stomach, L-DOPA. The dictum of giving L-DOPA is because I am sure nowadays general practitioners don't treat all these things, but it can be done because it should be done actually. Because old people, who will treat the old people? The specialists will not treat. So GPs have to treat. So the dictum is start low and slow. That is carbidopa and L-DOPA combination. Some other drug is also there. Combination drug is the one which we give. Give 50 milligram, 15 milligram. 50 plus 15. It's called a SYNDOPA. SYNDOPA, so many other plant names are there. SYNDOPA, once a week early morning, empty stomach for 1 week. Now build it up next week with a lunch dose, lunchtime dose, then dinner time dose. Main side effect is nausea. So if people get nausea, vomiting, start an anti-nausea drug like domperidone. Domperidone, the usual dose, about 15 minutes or 30 minutes before giving L-DOPA. Then, all people will not learn, especially those who are not having real Parkinsonism will not respond to L-DOPA. So, but to prove that it is not responding to L-DOPA, you have to give good dose, about 600 milligram equivalent of L-DOPA for about maybe around 1 month or so. Then still they are not responding to it, means it may not be Parkinsonism. May not be Parkinsonism. There are supplementary drugs which will increase dopamine. The dopamine metabolism can be affected by certain drugs. Especially, there are two ways which dopamine will metabolize. One is through the what's called a COMT channel. Another one is there's one more is there, and that the second one is that is the what is that? It's called selagelin, or one more drug is there, a group is there. But I'm not concentrating on this because they can be given by specialists. They actually are not as effective as L-DOPA. You have to give a full dose of L-DOPA before giving all these things as a supplement. And also there are drugs called what are called dopamine agonists, act on the this one receptor for dopamine. Dopamine agonists. Dopamine agonists. There are group of drugs called ropinirole and all those things. But they have significant side effect also, not as effective. Sometimes it is given to a certain section of the population by the movement specialist. But one thing which all GP and others should know is a drug called this one, apomorphine. Apomorphine is not morphine. It's a morphine derivative. But it has been completely morphine, the opioid part has been completely destroyed, and they made it into dopamine agonist. That's apomorphine. Apomorphine was not available. Now it's available, especially in the sublingual tablet. I don't know if injection and infusion is not still available, but it's a little pricey. But this one apomorphine is still available in India. Sublingual tablet, 2 milligram. One brand name is called, I think, Zydus Carlis marketing is Cyprima. See, apomorphine can be given to people having you are not after the L-DOPA is given for a certain period of time, 4-5 years. They will have all the adverse effects as well as become less effective. Adverse effects is what's called dyskinesia. They will have extra motor movement. So and also the extra motor movement, even if it is there, you should continue L-DOPA, because main thing is not hyperkinetic disorder. Main thing is hypokinesia. So to improve hypokinesia, you should give L-DOPA, even if there is other dyskinesias like they can have various other movements, like even dystonias. Dystonias means certain muscles go into spasm. That's called dystonia. They can have tremor also associated with dystonia. That's a different kind of drug associated tremor, L-DOPA associated tremor. So such cases sometimes you can give apomorphine. At least give a little bit of apomorphine. And also when it becomes totally ineffective, L-DOPA, still you can give apomorphine in some cases. Apomorphine is available in India. So these are two drugs I would recommend, L-DOPA and apomorphine. The side effect of all these things is drowsiness and also falls. Somebody is falling. You have to be very careful before giving L-DOPA and apomorphine. Both can cause drowsiness, falls, vomiting, nausea, common to both apomorphine and L-DOPA. So if you ask me how long can you sustain the patient on drugs, The short answer would be about 5 years. Hmm? I mean, people live, the early onset Parkinson, people live a number of years. But drugs can become ineffective. Still, they will live. Hmm? Then some other drug treatment for non-motor symptoms like excessive sweating, beta blockers, postural hypertension. There is a drug which will increase sodium in the body. It's called fludrocortisone. Small dose, 0.1 milligram, 1 milligram, I don't know which one. Then even domperidone, which is given for nausea, can be given for postural hypertension. Domperidone. Cylor, I said injection botulinum. Hallucinations, quetiapine, that is our neuroleptic drugs. Then daytime somnolence, modafinil. Then before I conclude, I will just go into an entity called drug-induced Parkinsonism. It's quite common in old people, if you give this thing, the dizziness or the vomiting drugs, Stemetil, chlorpromazine, or Perinom for vomiting, metoclopramide. These are all can cause Parkinsonism. These are even other drugs also. They are actually neuroleptic drugs, prochlorperazine and metoclopramide. But even calcium channel blockers like sineresine, rarely lithium, fluoxetine, that is antipsychotic drugs, paroxetine. These can also cause drug-induced Parkinsonism. But drug-induced Parkinsonism will not respond to L-DOPA. You have to give them mainly anticholinergic. Anticholinergic means, the atropine-like drugs. One drug is called Pacitille. Pacitille. And of course, another great thing in this thing is called, I have already gone through Parkinson plus, that is with dementia, vascular Parkinsonism, following this thing, vascular injury like stroke. But vascular Parkinsonism, they will generally have gait apraxia. Gait apraxia means, difficulty walking, not be able to walk. So the severe Parkinsonism. Even vascular dementia is also very severe. Then you can diagnose it with CT and the deep white matter changes. And this is about Parkinsonism. Thank you very much for your patient listening. I hope it will be useful to at least some of you. I hope it will be useful to Karnagaran at least.